Assessing chronic aortic regurgitation requires a multi-parametric approach. For residents and fellows, the challenge lies in moving beyond simple color Doppler and mastering the quantitative metrics that dictate surgical timing. The following guide breaks down the gold standard flow metrics and quantitative assessments used in advanced echocardiography. The American Society of Echocardiography emphasizes three primary quantitative measures to define severe aortic regurgitation. Effective regurgitant orifice area less than 0.1 square centimeter is mild, 0.1 to 0.29 square centimeter is moderate, and 0.3 or more is severe. Regurgitant volume less than 30 ml per beat will be mild, 30 to 59 will be moderate, and 60 or more ml per beat will be severe. Regurgitant fraction less than 30% will be mild, 30 to 49% will be moderate, and 50% or more will be severe aortic regurgitation. Proximal isovelocity surface area is often more difficult in aortic regurgitation than in mitral regurgitation because the flow convergence zone is frequently constrained by the left ventricular outflow tract walls. Formula: effective regurgitant orifice area is equal to 2 pi r squared into aliasing velocity together divided by maximum velocity. Clinical tip: shift the baseline toward the direction of the jet, usually downward for AR, to a Nyquist limit of 30 to 40 cm per second. While PISA provides a snapshot, spectral Doppler provides insight into the hemodynamics of the entire cardiac cycle. Pressure half-time measures the rate of pressure equalization between the aorta and the left ventricle during diastole. For severe AR, pressure half-time is less than 200 milliseconds. Mechanism: as the LV fills rapidly from the aorta, the pressure gradient drops quickly. But there is a pitfall. PHT is highly dependent on left ventricular compliance and systemic vascular resistance. In acute AR or patients with high left ventricular end diastolic pressure, the pressure half-time will be short regardless of severity. Hollow diastolic flow reversal is one of the most specific markers for severe aortic regurgitation. Measure this in the proximal descending aorta using the suprasternal notch view or the abdominal aorta. Severe aortic regurgitation, a sustained retrograde flow throughout the entire duration of diastole, indicates severe aortic regurgitation. An end diastolic velocity more than 20 cm per second measured at the end of the envelope strongly correlates with severe aortic regurgitation. How to look for hollow diastolic descending aortic flow reversal in severe aortic regurgitation? That can be checked from the suprasternal view. First, obtain a color Doppler image of aortic arch and proximal descending aorta. Color Doppler will show the reverse flow in diastole in severe aortic regurgitation. Place the Doppler line aligned to the center of the aortic isthmus just beyond the origin of left subclavian artery. Hollow diastolic flow reversal in descending aorta with an end diastolic velocity above 20 cm per second is one of the features of severe aortic regurgitation. End diastolic velocity is measured at the peak of the R wave on simultaneous ECG. Velocity time integral of the diastolic flow more than 15 cm is also indicative of severe aortic regurgitation. Vena contracta represents the narrowest portion of the jet. It is relatively independent of flow rate and driving pressure. In severe AR, it is more than 0.6 centimeter. Vena contracta using 3D echo is superior for eccentric or multiple jets where a single linear diameter might underestimate the true orifice. When pisa is non-contributory, as in eccentric jets, use the continuity equation to calculate regurgitant volume. Calculate total stroke volume, which is equal to cross-section area of the LVOT into velocity time integral of LVOT. Calculate systemic stroke volume, which is equal to cross-section area of the mitral valve into velocity time integral of the mitral flow, assuming that there is no mitral regurgitation. Regurgitant volume will be stroke volume total minus stroke volume systemic. There is a low flow caveat. If the left ventricle is severely dilated or systolic function is low, traditional velocity-based metrics may underestimate severity. Always correlate with left ventricular dimensions. Example, left ventricular end systolic dimension more than 50 millimeter or indexed value of 25 millimeter per square meter. Here is a summary checklist for fellows. While presenting a case of advanced AR, ensure that you have checked the following. Is the jet width by LVOT ratio more than 65%? Is the pressure half time less than 200 milliseconds? Is there hollow diastolic flow reversal in abdominal aorta or descending aorta? Does the PISA effective regurgitant orifice area match the visual assessment? Is left ventricle remodeling in response to volume overload?